Hello and welcome to today's live Coffee Talk CME webinar entitled HIV Treatment and Prevention Services for People Experiencing Homelessness. This activity is supported by independent educational grants from AbbVie, Gilead Sciences, and ViiV Healthcare, and is jointly provided by Global Education Group and Integritas Communications. Now, let's turn things over to our presenters, Dr. Sarah Rowan and Dr. Arsalan Shah. Enjoy the program.
Thank you so much for joining us. My name is Arsalan Shah, and I have Dr. Sarah Rowan with me. We have a very excited topic today to discuss, so we'll jump right in. Our learning objectives are describe adaptations of rapid ART protocols to address needs of PH, competing needs of PH, review PrEP protocols that can be adapted for PEH, patient experiencing homelessness, identify community-based opportunities and logistics for co-location of HIV healthcare services with such. All right, and now I will hand it off to Dr. Rowan.
Thank you, RC. Hi, everyone, and welcome to this presentation. I'm Sarah Rowan, one of the infectious disease providers at Denver Health. So I'll be reviewing a variety of topics about HIV treatment for people experiencing homelessness. And we'll start with some information about the risk of HIV among people experiencing homelessness. So we know from multiple studies that the rate of diagnosis of HIV is higher among people experiencing homelessness than those who are housed. People experiencing homelessness have about a 50% less chance of attaining a viral suppression versus those with stable housing. And viral load is linked to degree of viral stability, of housing stability. We also know that people experiencing homelessness who contract HIV have a 27-fold higher risk of death versus those with stable housing. In this graph, you can see that the absolute numbers of people with HIV who are counted as homeless in the United States did go down during the early 2000s, but unfortunately we've seen it plateau and start to actually increase in the last 5 years or so. Next slide. We know that in the HIV care continuum, testing is the first step, and it's also the first step in test and treat, which is what we'll be spending a lot of time talking about today. So universal test and treat paired with rapid ART, so starting HIV treatment as soon as possible after diagnosis, can yield high levels of community viral suppression. Universal or opt-out testing can be performed in the emergency department, where many people experiencing homelessness seek care, and often that's the primary place where some people get care, though multiple studies have shown that linkage can be a challenge. Initiatives of opt-out testing have expanded to shelters and other community locations, and surveys have shown high rates of uptake of acceptability for HIV testing in shelters. Community testing may also include bathhouses, shelters, syringe service providers, homeless encampments, LGBTQ plus centers, community centers, drop-in centers, mobile units, special events, and sexual health clinics. So you can see there's really a variety of settings that we can offer universal opt-out HIV testing. And those places may increase accessibility for people experiencing homelessness. And then linkage to care teams can facilitate treatment initiation for those who test positive. Next slide. Linkage to care teams are the collaboration between multiple clinics and organizations. They are integral to the success of test and treat programs. The linkage to care teams can determine the best way to reach patients and to obtain patient contact information. Often, it takes more than just what's in the medical record to reach someone. So having a team that's trained and dedicated to really optimize the ability to reach someone is really, really an important tool. They can help with transportation or transportation vouchers to clinics. They can help with appointment scheduling and also locating the clinic that's going to be most effective or most convenient for the patient. They can assist with access to insurance or Medicaid enrollment, and with pharmacy support programs, which are really, really key to optimizing success in those early days after an HIV diagnosis and throughout care. Linkage to care teams can vary in size and scope, but many Ryan White funded jurisdictions have agencies that are funded for this purpose. Next slide.
All right, so I have a question for you, Dr. And what organizations does your clinic collaborate with to improve test and treat approaches?
So what we found is that working very closely with our sexual health clinic is the most important factor for optimizing test and treat. Many of our HIV diagnoses occur through our sexual health clinic or folks who've tested in the community, either at community-based organizations or through home testing, or maybe even were flagged as having a positive result when they donated plasma, are then funneled to our Linkage to Care program or Linkage to Care team at our institution or through our sexual health clinic. And from there, because we have protocols in place, we can get pharmaceutical assistance, we can get a provider to see someone right away and discuss HIV treatment as soon as possible after diagnosis. Other organizations will touch base on throughout the rest of the presentation.
Thank you so much. I would also like to add one of the success that we've had is partnering with our county. That they specialize on HIV and PrEP care, and we specialize on Hep C care, and we certainly do both, and they certainly do both, but they do definitely have the resources. So we have created systems and workflows that we can refer them, and they can then connect patients right away, and has been really a successful partnership with our county over here.
Yes, that's critical. As sort of a quasi-governmental organization where I am at Denver Health, we can relate to that. And we also work closely with our state health department. We get a lot of referrals and have a close partnership so that we can facilitate initiation, medical care, treatment, exam. So we talked a little bit about screening, about offering HIV testing. We talked a little bit about linkage to care, and we'll get back to that later. But what if someone is exposed to HIV? So a little bit about initiating non-occupational post-exposure prophylaxis. And that's the use of antiretroviral medication after a very recent potential exposure to HIV in order to prevent transmission. We know that medication must be started within 72 hours of possible exposure. So if a patient calls and says they're worried that they had an exposure to HIV, an exposure to someone who they don't know their HIV status, but it was in a way that could lead to HIV transmission, we need to start NPEP within 72 hours, and really preferably as soon as possible. It's important to test for HIV prior to initiating NPEP. So that we know if someone actually already had HIV. That won't tell you if there's been transmission at that moment, but that will tell you if someone had previously undiagnosed HIV. The client can then follow up with the prescribing clinician at around 72 hours after exposure to confirm that they received, or if they're starting medication, to confirm that they received the meds, and inquire about side effects, and really make sure that they can complete that full 28 days of treatment for NPEP. They can then discuss transition to PrEP, pre-exposure prophylaxis, if that's appropriate. We also recommend that they continue HIV and STI testing at regular intervals. And of note, NPEP is typically covered by insurance, including Medicaid or patient assistance programs on an urgent basis. Next slide. So then, for folks who've done 28 days of NPEP, they would consider transitioning to a PrEP regimen if it's appropriate. So who should consider that? Anyone who meets the eligibility criteria for PrEP and has had a potential exposure to HIV within the past 72 hours, so they would be eligible for NPEP and then consider starting PrEP. Anyone who's been prescribed NPEP and has ongoing risk HIV acquisition, and any client interested in PrEP, regardless of what they tell you about risk. We know from data that really if patients are asking for PrEP, it's important that we offer it to them. They don't need to prove themselves. So when should you start that conversation about PrEP? Typically early on. However, clients might be overwhelmed after an HIV exposure or concerns for an HIV exposure. So you can start by assessing their knowledge of PrEP and then providing some information, and then revisiting the PrEP conversation when they've come closer to completing their 28 days of NPEP. Next slide. How about starting PrEP? So we talk about generally start discussing PrEP with any person experiencing homelessness when they test negative for HIV. Not everyone who tests for HIV necessarily could benefit from PrEP, so it's a discussion. We also know that the 211 option, which is event-driven PrEP or on-demand PrEP, intermittent PrEP, can be very successful and can be discussed with all men who are have sex with men who are experiencing homelessness, because the 211 regimen is only approved for MSM. So the 211 is 2 pills of Truvada taken 2 to 24 hours before sex, and then 1 pill 24 hours after the initial dose, and then 1 pill 48 hours after the initial dose. So it winds up being 2 pills before, and then 1 a day later, and 1 2 days later. And that has become a popular option in many places, and may be a great option for people experiencing homelessness if they feel that they have some predictability with their sex lives. What we've found has been that there is a low baseline knowledge of PrEP among people experiencing homelessness in some studies, but people experiencing homelessness do express interest in PrEP following some education. It's important to combat medical mistrust and even to acknowledge that it exists and to recognize its validity. And also it's important to look at the low perception of HIV risk that some people may have, and then sort of help patients and clients to understand what their true HIV risk is. Uptake and adherence can be increased through access to free PrEP, to HIV testing, healthcare, and one-on-one counseling. And people experiencing homelessness with HIV have been demonstrated to have increased mortality and worse health outcomes, which we mentioned in one of our first slides, in those who are housed. So that kind of underscores not only is PrEP important for HIV prevention, but HIV prevention is especially important for people experiencing homelessness, because the consequences of HIV can be much worse for those who are not stably housed. Next slide. So a little bit about prescribing PrEP. Prior to prescribing PrEP, you need to identify patients at risk for HIV or interested in starting PrEP, confirm their interest and their clinical eligibility. And with clinical eligibility, there's not actually too many clinical requirements, but they should have a weight greater than 35 kilograms. They need a negative HIV test result, and that can be a rapid test if you also send a lab-based 4th generation or viral load test. They should have no signs or symptoms of acute HIV or opportunistic infection. If they have signs or symptoms of acute HIV, or if they've had exposure to HIV more than 72 hours ago, so outside the window for PEP, you'd consider sending a viral load in case they could be at the window period. And then we do want to consider the necessary labs, which we don't have to wait for the results of, but we need to have them ordered in a way to reach the person if they're abnormal. And those would be kidney function, as these medications are not recommended for people with very, very low kidney function, but typically that's not a common unrecognized condition. So then we also would order STI testing, cholesterol testing, depending which regimen we're using, and hepatitis screening. But you can initiate PrEP as long as there's a negative HIV test. You don't need to wait on all those other tests to come back. And then in this box, you can see the different regimens. There's TDF with FTC and TAF with FTC. And TAF with FTC is approved for MSM or transgender women. And then finally, most recently, we have cabotegravir long-acting, and that has just been approved for pre-exposure prophylaxis as well. And that's an every 2-month injection. And that is also approved for MSM and transgender women. A little bit harder to access in many places right now, so we won't focus on that too much. But hopefully it'll become easier to access in the coming months and certainly years. Next slide. So when we look at PrEP for people experiencing homelessness, unfortunately, there's a lot of barriers to prescribing PrEP, and a VA clinic, Veterans Clinic, in LA took a look at this through a quality improvement lens. And what they did was they looked at pre and post intervention prescriber prevalence of PrEP prescriptions and comfort with PrEP prescribing. And they looked at the different barriers, and this just sort of shows that there are a variety of barriers to prescribing PrEP, but they can range from how to identify the patients, comfort discussing PrEP with patients, understanding risk, dealing with stigma, and then infrastructure barriers like, does the clinic allow prescriptions for PrEP? Does the clinic support PrEP prescribing? And then the actual prescription, are there restrictions in terms of provider type or access to coverage, education? But they found that after this quality improvement project to look at all these barriers and educate clinicians and address multi-system barriers, they were able to increase the percentage of their providers who were comfortable prescribing PrEP from, I believe it was like 20% to 50%. So it really is doable if there's a concentrated effort. Next slide. Another interesting potential partner is substance use disorder centers, so the treatment centers. They can play a critical role in HIV prevention, treatment, and testing. And they're really potential access points for HIV testing and services. We know that the CDC recommends PrEP for people who inject drugs at substantial risk of acquiring HIV and for any person interested in taking it. And substance use disorder treatment centers are a primary access point for testing and HIV-related services. And one study of substance use disorder centers showed that they were the most frequent location of the patient's last HIV test. So really, I think it's critical to recognize that this may be the main line to healthcare that our patients and clients are receiving. So partnering with them for HIV testing, prevention, and treatment has a lot of potential to be effective and reach folks that are harder to reach in other places of the healthcare system.
All right. Thank you so much for sharing all that great information. A lot of prescribers ask me this as well. How do you bring up PrEP with patient experiencing homelessness?
So I think one thing that is really critical about bringing up PrEP relates to not only people experiencing homelessness, but anyone in general, and that is to take a good sexual history. If you're seeing a patient clinically, it's really important to take a sexual history. And when you take a sexual history, that's a perfect time to discuss PrEP because that's sort of integrated into your care visit and it's going to happen naturally. And that way it sort of standardizes things so that you don't feel like you're singling people out. People don't feel singled out. I think really, I can't encourage people enough to take a sexual history in every patient. Other times to bring up PrEP are certainly with HIV testing, because HIV testing is when people are going to be discussing their risks for HIV. So risk prevention is a natural response there.
Thank you so much for sharing that. One comment that I would also add is, I think you made a great point about normalizing the sexual history. And from a harm reduction lens, we also normalized drug use and the equipment use of that sort. So that also kind of helps us, again, not stigmatizing or targeting patients, but just having be part of a conversation with the patient. And that's another way that we always try to bring it up with the patient population as well.
Yes, that is a great point. That's good, especially given the topic of HIV among people experiencing homelessness, because there is a risk for sexual transmission. There's also a risk for blood-based transmission through injection drug use and sharing of equipment. So, yeah, absolutely. Talking about prevention is really inherent into all sorts of harm reduction principles. So moving on sort of our care continuum, we talked about testing and screening, we talked about linkage, we talked about PEP and PrEP. And what about rapid ART? Rapid ART has been a real game changer in the last 5 years. And that really refers to starting antiretroviral treatment as soon as possible after an HIV diagnosis. And that can be on the same day. So rapid ART increases the uptake of ART and linkage to care. And it decreases the time to viral suppression for individual patients and it improves the rates of virologic suppression among persons with HIV. So we've seen benefits on multiple levels of offering rapid ART or same-day ART, basically almost concurrent or soon after HIV diagnosis. We know that laboratory and genotyping results were not necessary for the recommended rapid ART regimens. We can go over that more, but basically we don't have to wait for genotypes. We don't have to wait for the other labs. All we need really is an HIV positive test result, and we can start HIV treatment. Ideally, people experiencing homelessness and really many people in general would be prescribed a single tablet regimen for ease of adherence. So what is U equals U? U equals U is so cool. It is undetectable equals untransmittable. So that means that a person who has durable viral suppression, meaning their viral load's been undetectable for the last 6 months, cannot transmit HIV to a sexual partner. And this is likely true for those with a shorter time of undetectable HIV, but we just don't have the data necessarily yet. But we know that more undetectable is better when it comes to preventing HIV transmission. And it's really been empowering for patients to know this. Gives them some self-confidence. We also know that this speeds up the time to getting undetectable when people know that they won't transmit HIV when they're undetectable. They can become undetectable their virus can become undetectable 1 to 6 months after initiating ART. Many of the newer regimens work very quickly. And adherence is essential, and that's really an important part of the discussion. But, we know from multiple studies now that there are really no linked transmissions of HIV when the HIV positive partner has a suppressed viral load. And that's looking at a variety of different types of sexual activity. And you can see, and the references are below, that there were 0 linked transmissions. So that has really led to the revolution of discussing U equals U. And we should discuss it in general in terms of HIV prevention, but really important to make sure that all of our patients who are living with HIV know about U equals U. Next slide. So thinking about rapid ART for people who inject drugs, we talked about sex, but what about injection drug use? 7% of new HIV diagnoses are in people who inject drugs, and that's a small percent, but it's quite significant. Diagnoses increased 13% among people who inject drugs from 2016 to 2019, with the largest increases among white men, and we also saw, increased 15% among men, 15% among whites, 33% among whites. We know that there's an increased rate of ART initiation among those who engage in opioid use disorder treatment programs, particularly medication-assisted opioid treatment programs. And the U equals U, so undetectable is untransmittable, is not proven with injection drug use and sharing of injection drug equipment, but some studies have shown that it holds promise. And we know that rapidly achieving viral suppression does improve outcomes for individuals who use drugs, individuals who are experiencing homelessness. So we think that most likely this can help decrease transmission of HIV as well among people who inject drugs. So a few other things about starting rapid ART. As I mentioned before, laboratory and genotype results are not necessary to start. We do still want to get those things cooking because that's standard of care, but we don't have to wait for the results to start HIV medicines. The recommended regimens are very potent and they have a high barrier to resistance. So we're unlikely to start someone on something that their virus is resistant to. Second generation integrase inhibitors and boosted darunavir are both recommended for rapid starts. And we've seen virologic success with dolutegravir and bictegravir regimens, even in patients with resistance to other medication classes. There's a few ART regimen changes that have been made because of baseline genotype resistance in studies of rapid ART. So it's really rare that the starting medication is not going to be effective. There's an improved safety profile, and it is recommended, though, that we assess for possible opportunistic infections. So So a lot of enthusiasm, just a couple things to keep in mind, which medications to start, getting the labs going, getting follow-up information, and then it is important to assess for possible opportunistic infections. If someone may have advanced HIV with a low CD4 count, an opportunistic infection, we don't want to trigger an immune reconstitution inflammatory syndrome. But typically most clinicians will be familiar with what to look for so they can start safely. Recommended ART regimens are listed here. There's a bictegravir-based regimen, dolutegravir-based regimen, and boosted darunavir-based regimen. And if a patient has acquired HIV while taking cabotegravir long-acting PrEP, then that patient has been on an integrase inhibitor, and the patient should initiate treatment with a boosted darunavir regimen. Long-acting ART is not among those regimens, you'll see, because that's not recommended yet for a first HIV medicine. It's not an initiation regimen yet. It's more of a switch regimen. We shall see how things go in the future. Next slide. So potential barriers to rapid ART are important to consider because they can lead to not implementing a program despite barriers that could have been overcome had they been previewed. So there are structural and systemic barriers. HIV testing may occur off-site. There can be complex eligibility criteria for some clinics. Some clinics only see people who have a certain CD4 count or lower. Some clinics only see people with a certain residence. It's important to think about access to medications for folks who don't have a payer source. So if you have a new diagnosis who is uninsured, then having a plan for accessing medication is obviously important prior to implementing a rapid start program. And then scheduling provider availability, will you be able to get the patient in to see a provider? So sort of thinking through those structural systemic barriers will be very important for creating a successful rapid ART program. There's also some things like provider and staff beliefs, like the idea that you have to have a genotype back, or you have to have your creatinine or your Hep B result. And that is something that we can address through education because that is not required. And then patient's readiness could also be a barrier. Coping with an HIV diagnosis, we don't want to pressure anybody to start ART if they're not ready. In my experience, and probably RC's as well, everyone I see who's newly diagnosed wants to start that day. But if that's not the case, then we're absolutely not pressuring anyone. Housing stability, sort of the focus of this webinar, can be a barrier if the patient considers it to be, but it is absolutely not a barrier in any guidelines to starting HIV treatment. Similarly, a variety of psychosocial issues can come up, none of which should be a hard stop on starting HIV treatment. So, overview of key facilitators and indicators. Key facilitators to starting HIV treatment as soon as possible and optimizing success. Tight working relationship between the testing sites and the rapid ART sites. So whether the testing sites are nonprofits, community-based organizations, outreach branches of a clinic, it's important to have a plan in place with an HIV treatment site. And warm handoffs, accessible linkage coordinators are really critical. This doesn't really work without a middle person. Early and sustained access to ART through insurance, through pharmaceutical assistance, through other grants or other programs. Expedited insurance and payer source and clinic enrollments can be very helpful. So having a plan to help patients as soon as possible to get onto a payer source. Same-day clinician visits are really critical to offer. And then close follow-up, patient navigation, ongoing education, a person to call if there are problems, retention services can all be helpful for promoting success. The ways success has been measured in many of the studies looking at rapid ART include median time to ART initiation, which you obviously see come down when people start same day as an HIV diagnosis or within the first week or so, and median time to viral suppression, which has decreased dramatically since test and treat initiatives have gotten started. There's some models if you want to read more about what other organizations have done, and it's kind of note. You'll see there was the rapid start in San Francisco, And they were really some of the pioneers. But this model has also been reproduced with great success in Atlanta, in Louisiana, and New Orleans. So in more resource really rich geographical locations, and then also more resource challenged locations. Next slide. And this graphic just really beautifully illustrates the really patient-centered approach to rapid ART, looking at all these different clinic visits that used to be required to start HIV treatment for people, and just narrowing down to one HIV start visit, which is really much more efficient and in many ways gives patients a lot more peace of mind. Next slide.
All right. So how can clinics increase education about rapid ART and ART logistics for patient experiencing homelessness? And we'll go to the second question after you answer.
Yeah. So I think that clinics that treat HIV have the most exposure to these concepts, but it's important that that there be a kind of clinic-wide consensus, because it does take a while to change provider perceptions, especially people who've been doing this a long time and have seen a lot of different things happen. So it's really important that clinics kind of review the data, talk amongst all their providers, and include the front desk staff, include their linkage to care team in these conversations, so that everybody understands that rapid ART is safe and in fact it's highly effective. And then everyone's concerns can be addressed, sort of the way we talked about, looking at those, kind of looking ahead to see what are these barriers going to be, and then being able to talk through them as a team. I think that can make a huge difference in terms of promoting rapid ART. And then the other thing is that there are a lot of clinics who don't treat a lot of HIV. Some, as we'll mention, some clinics that aren't primarily specialty clinics may also treat HIV, and so it's important to get the message out to those clinics as well that they are absolutely doing the right thing by starting HIV treatment as soon as possible, even though that's not the way it used to be.
Thank you for sharing that. And another thing for my systems admin lens, what we've seen be really helpful is just kind of providing the logistics to the providers and social workers or MAs, HAs, for example, like the paperwork, the intake paperwork and things like that. If we can reduce that, narrow that, providing DOF phrases and EMRs for providers to kind of have an easy start, providing the right insurance information, like if you're seeing a lot of them, to your pharmacist or who's ever helping navigate that, that really helps fast track some of those processes. It's not just the clinical education, it's also some of these, if you reduce the barriers for the staff, then they are very successful as kind of communicating to the patients and kind of moving that process along. And then we have a second question. So how has your clinic successfully initiated rapid ART and PH?
We've looked at a few different options, and I think two things that are really important are that our sexual health clinic providers are trained to start HIV treatment. So many of the folks experiencing homelessness in Denver seek care at a clinic that is funded fully for people experiencing homelessness. And it's a primary care clinic, family medicine and internal medicine providers. And they're really close partners of us here at the infectious disease clinic and the sexual health clinic. And so because we have experience and we have same day availability or next day or same week availability in our sexual health clinic, we're very comfortable starting folks on treatment and then working closely with the providers there for ongoing care. And I think that can be the model in many primary care clinics or many primary HIV care clinics, that if you want to have a central clinic to start people on HIV treatment, and then that gives you a little bit of breathing room to find an appointment in the next 3 to 4 weeks or the next 2 weeks if you think they need really close follow-up. But it doesn't have to be so so pressing to start it quite immediately. If you know that you've got a place where you can get people the information they need, the exam, the basic labs, and then over time find an available way to get that follow-up going in a place that will be their continuity care. I think that's one option that works really well, and that's what we've done at our clinic.
Thank you for sharing that. And one thing, being a pharmacist, I'll throw in a pharmacist plug. Depending on which state you are in, a lot of times you can have collaborative agreements with your pharmacist, whether it be PrEP or rapid or ART. And at least at some of our clinics, that's been really, really successful in collaborating with providers and pharmacists, and then having those pharmacists have, appointments available. Or if the pharmacists don't have appointments available, we kind of work with the providers to see if they have a work between both of them. Most of the time, we can generally see the patient the same day. So just being able to extend the clinicians for the patient access has been really helpful for us in our clinic.
Yeah, I can tell you that for us, we have also close relationships with our specialty pharmacists. So there's so much information happening when someone's first diagnosed with HIV. We're talking about U equals U, a natural history of HIV. We're talking about treatment, and then all the social concerns that can go along with a new HIV diagnosis. It can be hard to really find time to emphasize the side effects of treatment, adherence, medication, and food combos. And so having pharmacists to re-emphasize some of those points that you may have covered or you may not have covered in as much detail is super helpful for patients. It's a lot to hear on the first day. So having multiple people talk about those things can be really helpful. Yeah. So kind of going on to the whole patient, as I mentioned, after an HIV diagnosis, we see things in some ways, but I think patients are seeing things in a totally different way than we are. And so it's really important that we consider our patients holistically. There's many competing priorities for people experiencing homelessness. HIV may not be the top of that priority list. And so care requires a team and potentially some external resources. And you can see this model here of many external resources here. It's really important to build relationships with patients from the initial linkage to care. And there's been some looks at incentivized care, and that can be successful in ensuring patients link to and remain in care for both HIV management and wraparound services. So you'll see kind of here the variety of partners and the variety of concerns that people are looking at. And the more we can help address many of these concerns, certainly some of this will be referrals, but to acknowledge how important this is, I think the more likely we are to optimize HIV success, but also holistic patient care. Next slide. So looking at retention in HIV care, I think there are some factors to consider, and we can sort of look at some of the individual factors for retention in care, substance use being a real big challenge a lot of times and something that we need to address. Housing, obviously, the more we can support folks to enroll in housing programs and housing wait lists and housing voucher systems to work with our social workers, the better outcomes we'll have. I mean, that's really one of the key priorities. HIV treatment, rapid start, PrEP, they're all critical and they all need to be offered. But recognizing that housing is healthcare, and so as soon as someone can get housing and anywhere on the housing continuum is better than nothing. I think that's the highest priority. Structural factors here. Also, peer education can be incredibly helpful for people. The social network is important to acknowledge. We also see that social support with skills building can be very helpful. Medication adherence, problem-solving skills, we need people where they're at, understanding their barriers and acknowledging the validity of those barriers, all really important in promoting retention in care. And just some clinic considerations from some of our frontline providers that we've kind of pulled together to really improve outcomes. Flexible scheduling, rescheduling without penalty for no-shows. Some places, really say no-show this many times, we're not rescheduling you. And I think for populations with less control, their less predictable lives, that's just not going to work. Daily drop-in appointments can be very helpful. Support for Medicaid and ADAP enrollment is critical. It's a beast to try to navigate all of that, especially if you're unhoused and don't have reliable internet access, don't have reliable sleep, don't have reliable safety. You really need support for some of these requirements. Ensure that HIV care is available at a variety of clinic locations rather than insisting that patients see specialists. I think this is really important, that HIV care be a team effort, and that we not insist that patients with HIV only get their HIV care certain places. We need to meet people in the place that's most convenient for them. Transportation vouchers can be helpful. Bus passes, Lyft, etc., ride sharing supports, a flexible refill policy. I think that omitting HIV medicine is worse than giving HIV medicine to someone who hasn't had labs recently or who has been behind on their refills. So we really need to be really working with patients to get the refills to them when they need them. If their meds are lost or stolen, getting them the refills as soon as possible. Some places will store medications for people and they can pick up a week's supply at a time. Some people prefer a 90-day supply. For many, having a shorter amount on their person is going to be safer. Trauma-informed care, there are many trainings for this, including some through this series, and I think that's going to go a really long way, probably much further than any of the structural components that we're talking about, to improving relationships and outcomes. Syringe access, critical for a variety of reasons, obviously for HIV prevention, Hep C prevention, but also for providing a safe space where people feel respected and accepted. And then wraparound support for other social determinants of health. These things are all really patient-centered and important. And next slide. So this was a study at the VA in Los Angeles that I mentioned earlier, where they looked at a variety of factors that were involved with collaboration between organizations. And they found that rapid testing in shelters was available to any adult. Flyers and loudspeaker notifications announced the staff visit for testing, and those were very successful. Transportation vouchers to county-run clinics were provided, and that was a way to get a confirmatory test and treatment initiation for folks who were screened at the shelters with rapid tests, and counselors that aided to appointment scheduling and follow-up. And so by doing this sort of pilot coordinated initiative between organizations, they did 817 tests at 3 shelters, and of those, 7 people did test positive for HIV and 5 were linked to care. So it was a successful intervention. So potential partners, again, I think thinking holistically, because for people experiencing homelessness, we can't stay inside the box. Specialty clinics, sexual health clinics, pharmacy, the FQHCs and other community health centers that support people experiencing homelessness, and maybe the frontline healthcare in your community. Substance treatment centers, syringe service providers, shelters. Shelters can be great partners for healthcare and linkage to care. Other organizations that support people experiencing homelessness, those who do street medicine, those who do street outreach, and then certainly your health departments.
All right. So last discussion question, I believe. What examples do you have of clinics coordinating with external resources to improve HIV care for patients experiencing homelessness?
I think one really critical partner is our syringe service providers. We have to have release of information. We can't violate people's HIPAA rights. But the more we coordinate with those partners, the better, because that's often a place where people are getting care and they trust the staff there. And so that can be a great way to get people their medications and get messages to people. And certainly our primary organizations that support people experiencing homelessness in Denver, they're great partners for HIV care.
All right, thank you, Dr. Rowan. I believe that is the end of the our presentation, and I do have some questions. There's a lot of questions, it seems. So I'm going to try to rapid fire them over the next 10 minutes, and I'll try to chime in as where I can. So first question that I have is, how can an organization ensure privacy with testing events in location like encampment when delivering a positive result? Great question.
Yeah, it's a very good question. I think that we've done some testing in encampments, and if you set up a centralized area, and then especially if you work with folks who are used to doing street outreach, so maybe not your organization, but you have a partner organization, then kind of working through various tents and groups of people to come to your central spot where you're located, and having a dedicated kind of siphoned off area, it is going to obviously be very hard to be soundproof there. We also will do a van. So we'll bring a large van or a mobile unit, and a lot of times we'll have sort of recruitment throughout the park. And then folks can come into the van for a private space, and that way you have a little bit more soundproof. But I think it's a really important practical consideration.
Thank you for that. And I would just like to reiterate, our clinic does not have a van, but we do have small tents. So we try to use space. So we'll create like a couple of steps down, so there is that privacy there. So there is people are walking away from where they're actually getting tested. So then we can have some of those private conversations, or have like a more personalized education based on what personal risk factors are. Right. The second question I have: how successful is outreach testing with SSPs? Do you still see higher rates of positives within the population?
Yeah, SSPs are some of our highest rates. I think HIV testing has changed so much in the last 5 to 10 years. People can get tests through the internet. They can get rapid home tests, and so it's a moving target. But consistently, the syringe service providers will diagnose between a handful and maybe as many as 10 cases of HIV a year, and so that has got to be a continual go-to spot for us.
Yeah. All right. Which PrEP regimens require cholesterol screening, and how would the result change management in the setting of a PrEP?
So the TAF-based regimens have been associated with increases in cholesterol, and so it's kind of important to think through this took us a while to figure out our protocol, how we were going to do this in our sexual health clinic, because we're not in the business of treating dyslipidemias. So just knowing, and Arsa, you could probably speak to this more than me, about the risk of dyslipidemia with TAF is important, so that when you start people, you kind of have some predetermined thresholds for if you're going to switch to TDF or manage the dyslipidemias or work with primary care.
Yeah, some of the practice are changing right now with our patient population when we work with the patient experiencing homelessness, especially the social determinants of health that they have. We tended to lean more towards, if it was not a significant interaction, leaning more towards treating dyslipidemia versus trying to change the regimen, because that on its own, dealing with insurance and all that, could have been challenging for us. So just a postural approach from our organization is trying to figure out the interaction risk, and then trying to lean more on towards treating the dyslipidemia aspect of it. All right. Can you identify partner with agencies that interact with individuals and families before becoming homeless to increase knowledge and awareness with more at risk of becoming homeless?
Well, that's really the goal. Certainly preventing homelessness is so important. And I think from high-level policy changes that we can advocate for to individual level interventions, that is critical. And so we're kind of talking about people experiencing homelessness, but prevention is really important. In our infectious disease clinic, we have a social worker, and we have a whole sort of social support wraparound team that meets with folks who are at risk for homelessness and looks at ways to prevent that from happening. We have pretty close relationships with some of our service organizations who also have access to housing. So if we have people who are unstably housed, staying with, with a friend or in an unsafe situation, we can get people into emergency housing. We can get people on voucher systems. Our state health department has a critical event system that will provide a certain amount of funding for even hotel vouchers or for rent assistance if needed. Will help with electrical bills or things like that. So I think the more proactive we are, the better. And some can be, again, if your state health department offers something like a critical events program, working with your social worker in your clinic, those are very, very important, no doubt.
I love that question too. Work for Central City Concern in Portland, and we are a housing facility with healthcare as well. And again, just putting my management admin hat on, is so much more cost effective as well to prevent somebody from becoming homelessness versus having somebody who is already experiencing that and trying to get back them in the house too. It's kind of like from a healthcare perspective, it's also prevention of a disease versus treatment of a disease. It's just so much easier to do that and more effective. One question. I understand viral suppression as someone who has a viral load of less than 200 copies, whereas someone who is undetectable has an undetectable viral load, aka 0 copies. Are these two terms interchangeable when discussing U equals U?
Yeah, they are. So many of the studies looked at a threshold of 200. Which is higher than we use now in most of our clinics due to technology. But when a lot of these studies started, 200 was the threshold. So you can kind of look at the studies being a threshold of under 200. For us, we're really, aside from a blip, generally if someone has a persistently low-level viral load, low-level viremia, I think we're definitely going to explore that. So I think in terms of the U equals U, yes, a lot of the times they use that 200 threshold. I would definitely encourage my patients to get as close to a viral load of 0 or less than 10 or whatever your current threshold is to feel more confident with the U equals U idea.
Thank you. I know we're just a little bit over, just 2 questions. I'm just going to try to power it through. One of the questions, and I can probably take this one, it says, can you recommend ways to ensuring transferring care to a clinic if a group is only doing testing and cannot treat, does not result in losing in patient to care? MOU templates and potential pitfalls would be tremendously helpful. So again, something that we do at Central City Concern, we partner with opioid treatment providers, OTPs, and that's within the last year. And we have developed MOUs, we have developed protocols. We do share patients. Every time a patient gets interacted over there, we have signed bi-directional ROIs, and we then share that patient active list. We have some sort of a tracker, whether it be an Excel sheet or whether we're using an outside vendor. And then our providers, his job is from once the person is tested at that location, and then once you start treating, we have coordinators that kind of go through those patients on a monthly basis, and then we connect with our test to treat partner or testing partner to kind of follow up on those, and then they help us with either warm handoff and linkage to care. So that's one of those things that we already do. And again, you guys can look me up on LinkedIn if you want to reach out. I'll be happy to provide those templates and talk more about that. And then last question, have your clients who are experiencing homelessness had issues with storing PrEP or HIV medications, either from being stolen or lost during encampment sweeps? If so, do you have any successful strategies, solutions to this type of barrier to help clients access, store their medications?
There's a couple options. We work with our syringe service program. They'll store medications for people. Our opioid treatment facilities, they use medication-assisted opioid treatment. Sometimes they'll store HIV medicines for people. I think those are really, really patient-centered, and patients really appreciate that because those are places that they go regularly, so they can get a 1-week supply or 2 days or daily supply whatever they need. I think those are great options. Working with your pharmacy to make sure that they're willing to work with you and with insurance to get refills quickly for folks whose medications get stolen or lost. And then some of the shelters have storage facilities, so they can lock. People have storage lockers at shelters as well. Those are some options, but I think it's an ongoing challenge. It's very, very difficult.
Really is. And one thing that we're currently exploring with our Board of Pharmacy in Oregon as well, which I know that certain agencies that do that. So within our clinic, we're trying to store some Amazon-style lockers that come with a certain protocols, so our patients can then access within our clinic as well. So along with OTPs and other places, we're doing it within our clinic. So hopefully they can come and access, and we have like the specific protocols and requirements that have to go with that.
And I just want to jump in with one more thing. Long-acting HIV treatment through cabotegravir or rilpivirine is really exciting, and it's very new, and a lot of places are having trouble accessing it. Certainly cabotegravir for PrEP has been challenging, but we have more people that are actually getting the cabotegravir combination for HIV treatment, and that's an injection every 2 months. So there's challenges with getting to clinic every 2 months, but that's got a lot of potential for folks who have trouble storing medications for a variety of reasons.
Absolutely. That's a great call out. Thank you all so much for joining us.